Hi, this is Jan Johnson. Welcome back. Today I'd like to talk to you about nursing care of the family during labor and birth. True labor begins with the first contraction and ends with the birth of the baby, delivery of the placenta, and the mother and family begin the attachment process with their newborn. The focus of nursing care is to assess the patient and her fetus, support the pregnant patient and her family during labor, and do everything possible to ensure the best outcome of a healthy mom and baby. Now I'd like to talk to you about the 4 stages of labor. The first stage, which is broken up into 3 phases, the latent, active, and transition, is the longest stage of labor, and that's from the onset of contractions to full effacement and dilation of the cervix. Now, the first stage is going to be longer in a null parous woman or someone having their first baby than it is with someone having their second, third, or fourth baby. So that is the one stage that's significantly longer. The second stage has 2 phases, the latent and active pushing, and that's from when the patient is fully dilated, the cervix is fully dilated, until the birth of the newborn. The third stage is from the birth of the fetus or newborn until the delivery of the placenta. And the fourth stage is delivery of the placenta until the mother stabilizes. Now, stage 1 is the latent phase. That's from dilation of 0 to 3 centimeters. Especially in the first-time mom, the cervix is going to efface first before it dilates. After, if it's a multiparous woman, she's going to efface and dilate pretty much at the same time. But for that first-time mom, she's going to thin out, efface, before she dilates. But this is from dilation of 0 to 3. The mother has feelings of excitement and anticipation. We can still use diversional methods to pass the time. She may start to breathe a little more intensely during contractions, but in between contractions, she's fairly comfortable. If you'll notice on these pictures, you see the mucus plug, the cervix, and the vagina there. And you can see with the cervix how thick it is. And as the next few slides will demonstrate, you'll see how that thins out or effaces. And that mucus plug usually lets loose before the woman goes into labor. It can be up to 24 hours, 48 hours even, but it's generally a sign that labor is going to be coming. So the active phase is a little more intense. That's from dilation from 4 to 7 centimeters. The mother's feeling more serious. She's working at these contractions. This may be the time when she has some pharmacological pain relief, or she uses non-pharmacological pain relief measures. Contractions can be anywhere from 3 to 4 minutes apart and last 40 to 60 seconds in duration. But everything's moving along quickly. It's really serious at this point for the mom. Now, if you're looking at this picture over on the left, you'll notice how that cervix is now thinning out. And this particular picture shows the bag of water still intact, but at this point they may be broken. Now, the transition phase of stage 1, that's from when the patient is dilated between 8 and 10, or completely dilated. This is the greatest maternal discomfort experience. She may say, I want to quit. She may feel like she's going to have a bowel movement, which is the baby's head. She may start shaking. She may hyperventilate. We need to be really careful when we give medications for the mom's pain because they could cross over to the fetus if delivery comes quickly after we give the medication. And again, on the picture on the left, you'll see that that cervix is pulling up and exposing the head into the vagina. So the contractions are about 1 to 2 minutes apart and last 60 to 90 seconds in duration. Now, on this particular picture on the lower right hand corner, you'll notice the little spikes, and that is from her breathing in and out. So she's usually in really conscious breathing, like that type of thing, at the peak of the contractions when the pain is the worst. So for care management, the null parous, or the woman having a baby for the first time, they usually seek admission during that latent phase where it's 0 to 3. The multiparous woman, someone who's had a baby before, they don't usually come to the hospital until they're in the active phase, somewhere between 4 and 7. Of course, this is all individual and these are generalizations. But it's always difficult to know when they should come into labor, and so they may make a phone call and have questions, but the patient should always be instructed to call her primary health care provider or come into the hospital if they need to be checked. They feel they need to be checked. But the next slide will give us some insight as to whether the patient is in true or false labor. Okay, so differentiating between true and false labor. Contractions occur at regular intervals. Contractions increase in duration and intensity. Discomfort begins in the back and radiates to the front. If a woman gets up and walks, it intensifies her contractions. Resting in warm water does not decrease the intensity. But the true indicator is that if the contractions produce cervical change, then we call it true labor. So it has to be measured over a period of time. Now, if a woman isn't sure, her contractions may be irregular, they don't increase in duration or intensity, and sometimes they can be really, really intense. But they're usually lessened by walking, rest, or taking a warm bath or a warm shower. This discomfort is felt primarily in the abdomen, and these contractions do not produce cervical change. Sometimes people will call these Braxton Hicks contractions. But when you're the patient there and you're uncomfortable and you're at home and you're not sure what to do, your bag is packed, everything's ready, it's often a very stressful time and a difficult situation to be in because you don't know whether you should go in or not. And sometimes when someone's water breaks, they're not sure if they've actually peed their pants, and it's just all those things. Even on very educated women, sometimes these are very difficult decisions. But hopefully this graph will help you decide. EMTALA, or the Emergency Medical Treatment in Active Labor Act, is a federal regulation. It was enacted to ensure that a woman receives emergency treatment or labor care. Nurses must be familiar with their responsibilities. Agencies must have policies and procedures in place to ensure compliance. This can also be located under legal tip on page 402 in your text. But basically this says if a woman comes in and says she's in labor, the hospital doesn't have the right to say she's not. So they're going to be obligated to deliver care to see if she's in true labor. Okay, so during the assessment, we're gathering our admission data, and during this time we want to orient the patient and her family to the room and the facility. Upon admission, review her medical, obstetric, and prenatal history. If the woman has not received prenatal care or her record is unavailable, then refer to the table in your textbook for pertinent blood work that should be drawn. Also inquire about any desired birth plan, including any cultural considerations, preparation for childbirth, the level of comfort and coping strategies she has, and who is their support system. This is a good time to share with the woman and her family what she can expect from the nurse. How the bedside nurse establishes trust greatly impacts the patient's perception of their nursing support during labor. They will remember this 30 years from now, how they were treated, and you only have a few seconds to make a great impression. So I'm always very mindful about how I'm presenting myself to the patients. When admitting a woman into labor, it is important to do a thorough head-to-toe assessment. Establish what her baseline vital signs are, and perform Leopold's maneuver to determine the position of the fetus presenting. Assess fetal status by placing an external monitor and contraction toco on her abdomen to obtain the fetal heart rate, the variability, and periodic changes. So once the contraction monitor has been connected or applied, we can establish the frequency and the duration of the contractions. Remember that to measure the frequency, we time them from the beginning of the first contraction to the beginning of the next contraction. The duration is represented or measured from the beginning of the contraction until that contraction ends or subsides. The intensity or strength of the contraction with external monitor is a subjective measurement, and we often palpate the fundus to determine the firmness. If the patient presents with active bleeding or leaking of fluids, you cannot do a manual vaginal exam. The healthcare practitioner needs to do a sterile speculum exam to visualize the cervix and assess the cause of the bleeding. If the patient doesn't present with bleeding or leaking of fluids, though, the labor nurse or the healthcare practitioner will do a vaginal exam to assess how far dilated she is and how far along in labor. When we know her dilation, effacement, and station, it will give us a better indication of how her labor is progressing. When we establish the fetal heart rate and compare that with the contraction pattern, those are called periodic contractions, we can begin to assess the status of fetal well-being. Remember that we look at the fetal heart rate in relationship to those contractions to determine if we have a reassuring or non-reassuring fetal heart rate tracing. And you remember from chapter 15 that we categorize these findings into category 1, 2, and 3, with category 1 being optimal and reassuring us that the fetus is well oxygenated. Category 2 and 3 represent reason for concern and require intervention and further evaluation. Once admitted, we're probably going to obtain a clean catch urinalysis to check her hydration status, nutrition status, infection status, and to rule out possible preeclampsia, which would be protein in the urine with an elevated blood pressure. Some blood tests will include the red blood cells, the white blood cells, hemoglobin, hematocrit, and platelets. Other tests include ruling out group beta strep. If no antenatal record is available, the test is determined by an anorectal and vaginal culture. If it comes back positive, the goal is to give antibiotics to the mother during labor, ideally before her membranes rupture. If it's left untreated, the baby is at risk for being infected during delivery, and group beta strep can have very grave outcomes. You'll be learning more about that when you study the newborn. We'll also draw a type and screen in the event of a blood transfusion needs to be given for perhaps postpartum hemorrhage or something catastrophic happening during labor. If no prenatal care, the blood work would be drawn for STIs, HIV, and all the lab work that was reviewed in your antepartum discussions in box 8.1 on page 196. If the patient suspects that her water is broken, have healthcare provider obtain some amniotic fluid via a sterile speculum exam and check to see if it burns, or use nitrazine paper to see if it turns blue. If it turns blue, it's most likely amniotic fluid, which is alkaline. Urine is acidic and will not change the color of the nitrazine paper. Those procedures are also described in your textbook if you'd like to look those up. We want to monitor the fetal heart rate closely if the membranes are artificially or spontaneously ruptured. The umbilical cord can slip through the cervical opening if the fetal head isn't applied to the cervix. That would be called a prolapse cord. And we want to check the maternal temperature at least every 2 hours, especially if the membranes have been ruptured, to assess for an ascending infection from the vagina to the amniotic sac. That can result in chorioamnionitis or placentaitis. So once we orient the patient and the significant other to the environment, and we explain all our anticipated assessments and procedures, we want to start providing some physical care measures. Regarding general hygiene, we want to make sure we're cleaning the perineum frequently, especially if the membranes have ruptured. We want to have her wash her hands before and after she voids, offer a cool washcloth for her face, and change her gown and linens when necessary due to diaphoresis. Labor's a lot of work and they're going to sweat a lot. So some institutions allow showering or using a jacuzzi tub or some bathtubs, but I've not seen that happen as often. That may be more common in freestanding birthing centers, but some of the hospitals do have those facilities. We want to monitor labor progress and fetal well-being. We want to make sure that she has enough nutrients and IV fluids, so we're going to maintain the IV and provide ice chips and clear liquids if allowed to prevent dehydration. Elimination, we want to encourage voiding every 2 hours, and if you remember in simulation as we were looking at those pictures of when that head descends, it's often difficult for the mom to void because her bladder will fill up, but it's being compressed so much. So we need to make sure, especially if she has an epidural or something, because that'll numb her down there, we want to make sure that we're offering her an opportunity to void every couple hours, and we may need to straight cath her at times if the bladder starts filling up too much and actually holding the head up so it can't descend down. Bowel elimination. Whenever a woman complains that she needs to have a bowel movement when she's in labor, we need to do a badge exam to make sure it's not the baby actually coming. We can't always predict the timing of these things. So if it's getting close and the head's way down there, we may want to offer a bedpan to her. We don't want her to get up and ambulate to the bathroom at that point. When possible, though, we want to encourage ambulation. But in order for that to happen, we need to make sure that that presenting part, or the baby's head, is against the opening to the cervix, and the membranes are usually not ruptured. Once they rupture, I see them not walking quite as often, but certain institutions may have a little bit different policies. So provide comfort through frequent position changes, effleurage, which is a kind of fanning out of your hand during massage. She might want to focus on a single item. They sometimes bring in an item from home. Hydrotherapy if allowed. The caregiver presence brings comfort. We may want to push on her sacrum, sometimes with the ball or the ball of our hand, kind of as a counter pressure. We may want to give a back rub, or she may request some analgesia, and we may administer that as requested by the patient and ordered by the healthcare provider. So we want to teach, reinforce, and support the use of relaxation, visualization, and long relaxing breathing patterns. We want to encourage her to rest between contractions, and we want to document in the patient record and continue to give status updates to the healthcare provider. As we look at diagram C on this slide, it depicts the compression of the aorta and the inferior vena cava from the weight of her gravid or pregnant uterus when the mother's in the supine position. So that's represented by the red is the aorta and the blue is the inferior vena cava blood vessel. In this position, supine hypotension occurs. When this occurs, you will see pallor. She begins to lose all her color. She may have clammy cold skin, sweating, breathlessness. She may have tachycardia, and the patient may complain of dizziness and or she feels like she's going to faint. When and if this occurs, immediately reposition the woman on her side to displace this gravid or pregnant uterus, as in diagram D, until her vital signs stabilize and her signs and symptoms subside. So you can see that hip wedge in the lower right hand corner. So whenever we have the woman, actually she should never really be on her back. She should have a hip wedge from one side, under one side or the other, as we're turning her to keep her off her back when she's laying down flat, or even in a semi-reclined position. So we always want to be mindful. So pay attention to those signs and symptoms that I just mentioned. And here you can see in figure D how the aorta and the inferior vena cava now are fully open and able to perfuse just by getting the weight of that baby off her, off her major blood vessels, I should say. And pictures A and B show the inferior vena cava in different positions. So when she's in an upright position, it's not being compressed, but when she's lying on her back, it is being compressed against her spine. And in this picture, we're kind of showing how the fundus firms up, the fundus, which is the top of the uterus, how that gets hard with each contraction, and it actually raises off the normal abdomen and it tightens. And that's what we're feeling when we're palpating her abdomen lightly to feel during the contraction. And figure B is the beginning of a contraction and the beginning of the next contraction. You can see arrow to arrow on the bottom where when we're timing the contractions, we go from the beginning of one to the beginning of the next one. But the duration of a contraction, that's from the beginning of one contraction to the end of that same contraction. And then in between, we call that the relaxation stage. But also, when they have internal monitors, that is going to have a measurement, and it's going to be called the resting tone. So the nursing diagnosis associated with labor and birth can be found in your textbook on page 416 and 417. You should know the care associated with each of these for testing purposes. They include anxiety related to labor and the birth process, acute pain related to increasing frequency and intensity of the contractions. And during these pictures right here, you can see that the woman's using different techniques and different positions to try to help alleviate some of that pain. She may have risk for impaired urinary elimination related to sensory impairment secondary to labor, a risk for ineffective individual coping related to the birthing process, and fatigue related to energy expenditure required during labor and birth. Again, this is an example of the squatting position, and this is a wonderful position. It helps bring the head down. It doesn't put as much pressure on the baby. The inferior vena cava is flowing freely. There's no compression. Sideline, the bottom picture, is showing another very helpful position, and the woman on the left, the caregiver or the family member, is doing sacral pressure. She's actually rubbing on the lower back during the height of that contraction to help give her some relief. Now this is an example of using a birthing ball, and the midwife there, or the nurse, is listening to the fetal heart tones, trying to get them tuned in. But that woman looks quite comfortable in that. So nursing care, who can support the patient during labor? Well, that would be the nurse, the father or the birth partner. We have doulas, who are women who are usually nurses trained, but I'm not sure that they have to be nurses. They come in and they're labor support people. They're their right-hand people during their labor. Grandparents may be the support person. Now, siblings during labor and birth. Parents who want their children to attend birth should prepare the children with age-appropriate material and appropriate for their developmental and maturational level. A parent will usually know if it's going to be a safe environment for a child to be. And it's very important that we're non-judgmental during this, but try to help this family make it a good birth experience. Now, there may be times if things go bad, we may need to have a plan and talk with the family ahead of time that if something happens to the mom and interventions need to be done, that somebody will be available to take that child out of the room. Or if the child isn't tolerating it well, there's someone to watch the child besides her support person. So things just have to be in order if the siblings or the patient's children are going to be coming in to watch. Now let's talk about the second stage of labor. That begins with full dilation of the cervix and ends with the birth of the baby. So this is the pushing phase. But it goes into two phases, the latent or passive phase and the active pushing or the descent phase. So labor down is a term that's used, and that refers to the descent of the presenting part with the uterine contractions without the mom actually pushing. So the body's still contracting. Remember, the uterus is a big muscle. As that muscle contracts, it pushes that head down further into the pelvis. So laboring down would be the body's still doing all that work, but the mom doesn't have that urge to push yet, or they're trying to keep her from actively pushing. So that's going to be the passive phase, and that's called latent. We might also use that in a patient with a severe cardiac problem, and we don't want her to exert a lot of energy, so they may let her labor down, give her an epidural and let her labor down, keep her as comfortable as possible and let labor happen naturally, as opposed to the mom joining in with those contractions and actively pushing. So once the fetus descends enough, the pressure of the fetal head pushes on the stretch receptors of the pelvic floor, and that stimulates a release of oxytocin from the posterior pituitary gland. This increases the intensity of the uterine contractions. This is called the Ferguson reflex, and it causes the woman to want to actively push with the contractions. Crowning is when the fetal head or presenting part is visible at the introitus or the vaginal opening. And your book will show that, and I believe we have a slide in a minute that'll show that. So the latent phase is when the cervix is completely dilated before the woman has the urge to actively push with the contractions. Often when the woman has an epidural, she's comfortable enough not to push, as I mentioned. Research supports that having a patient labor down actually shortens the time she needs to actively push, but it doesn't necessarily shorten the length of the second stage. The woman may experience intense pain sometimes, called the ring of fire, as the vagina stretches and the fetal head is crowning. So be sure to review the table in your text to review the signs and symptoms of impending birth due to the second stage of labor. In regards to maternal position during the second stage, all research supports that the woman be in the upright position, possibly walking, sitting, kneeling, or squatting. It's more beneficial for the mother and baby, but current regional practice doesn't usually support this. It's very frustrating. The increase in the use of midwives and properly educating the patients so their birth plan supports this position will hopefully change this practice in the future. So bearing down with the Ferguson reflex is involuntary. As the woman bears down, she may have a strong expiratory grunt. This is called open glottis pushing, and it's to be encouraged. As a student observing a birth, it isn't our place to interfere with the labor nurse and the nursing support she's giving. Past best practice for labor nurses was to encourage the woman to put her chin to her chest and bear down, holding her breath for a count of 8 to 10, and then take a quick full breath and do it again until the contraction is over. I did that for years and years and years. That was the preferred method of pushing. Of pushing. That's called closed glottis. But now best practice says open glottis is better, and it allows more oxygenation. So if we were the staff nurse, we can support the woman by telling her what a good job she's doing and inform her of the progress you are seeing. So as that woman is pushing and pushing and feels like she's pushing her brains out and she's getting fatigued, it's nice to have a little cheerleader there to support her and tell her as she's progressing. There's nothing better than to hear all this work you're doing is actually making progress. So the fetal heart tones patterns will need to be monitored frequently. If the tracing is interpreted as a category 2 or 3, the intervention should be done immediately. Make sure the mother isn't lying flat on her back. If so, put a hip wedge under her and reposition her on her side to improve perfusion to the baby. Keep the healthcare practitioner updated of all fetal heart rate issues as well as document these findings. As we give continuous support to the woman in the second stage of labor, we need to also support the significant other if they are stressed or getting tired. Offer nourishment when possible and have him eat away from the mother so it's not right in front of the mom who can't eat and she's not feeling very good. Most women laboring in the hospital labor and give birth in the same bed. The nurse or healthcare practitioner may need assistance in breaking down the bed to prepare for delivery. Hopefully you may get to support one of the woman's legs while observing labor so you can get up close and get in all the action. These are diagrams of some of the different positions that the beds can break down into. And you'll see the last picture on the bottom. That's her actually sitting up. This is an example of a delivery pack or in preparation for delivery of the baby and all the instruments that are used. This is charged to the patient when the sterile supply is opened, so they be careful not to open it too early, only when they're pretty sure that the patient's going to result in a vaginal birth, not a cesarean section. Now this is the crowning that I was referring to. So you can see the progression, and this is called a view of the introitus, so the opening of the vagina when you can start to see the head. And as that baby descends, the picture letter D would be, these are all starting to crown, but D is really at a +2, +3 station. Remember when we talked about the cardinal movements of labor in chapter 13, you're going to want to review those as the mechanism of birth. So perineal trauma related to childbirth can be very significant. It can be minor or it can be significant. So lacerations to the perineum or the surrounding tissues may occur during childbirth. Third and fourth degree lacerations most commonly occur after a midline episiotomy is performed, and as that baby's head comes out, or the posterior shoulder, the shoulder that's down towards her rectum, that shoulder bursts through and extends that episiotomy and tears it down, sometimes into the lining of the rectum or sometimes into the rectum. So first degree lacerations only involve the epidermal layers. If it's not bleeding, it may not need sutures to repair it. A second degree tear or laceration goes through the epidermal and into the muscle and fascia. That requires sutures to repair. The third degree extends into the rectal sphincter and requires repair. And a fourth degree laceration extends through the rectal wall or the mucosa, and those are quite serious. That woman is going to have a hard time passing that first stool after birth if she has a fourth degree, and sometimes even a third degree. She's going to need a stool softener and make sure she has some pain medicine on board. And we're going to want to, if she's been taking her iron like a good mama, might have hard stools. So we need to be very mindful if a patient has a third or fourth degree that first bowel movement may be very, very uncomfortable, pulling against the stitches. So vaginal and urethral lacerations are not uncommon, especially in a rapid second stage of labor. So when she's pushing and that baby shoots down the birth canal quickly, it can tear the inside of the vagina, and as it stretches so quickly, it can cause urethral lacerations. If they are severe enough or they bleed, they may need to be repaired. So episiotomies are done by the healthcare practitioner if they sense that the perineum is going to tear. They are done midline and mediolateral, as I mentioned in simulation, and I'll show you a picture of that, and they will be repaired. Some physicians like to do episiotomies instead of letting the woman tear because they said that it's a straighter cut and it's easier to repair. But truly, if the woman's allowed to keep that baby on the perineum for a little while, it stretches naturally, and that stretching will go back. But once she's had scar tissue in there, next time around, that's probably going to rip or need to be cut again. So immediate assessment of the newborn, the priorities are to maintain a patent airway, support respiratory effort, prevent cold stress by drying and covering the newborn with a warm blanket and placing him on the mother's abdomen for bonding. Or if the newborn is compromised and not doing well, we want to transfer the baby to a radiant warmer for further assessment and intervention. Okay, so here you can see the midline, and the one off to the side is that would be a right medial lateral, or it can go off to the other side as a left medial lateral. And this picture comes from your textbook with a greater explanation if you need it. So the third stage is from birth of the newborn to delivery of the placenta. In here, in figure A, you can see it start to break away from the wall of the uterus. In B, it continues. C, it's kind of covering the opening. The woman's going to start to feel some vaginal fullness. And then D is when you see the lengthening of the cord. It kind of, as the placenta starts to come out and be delivered, the woman may give a gentle push along with that. So the average length of the third stage of labor is about 30 minutes for nulliparas and multiparas. So whether it's her first baby or the multiple baby childbirth experience, we're going to probably be under 30 minutes. Anything over that, they may call it a retained placenta and take the patient in for back to surgery for a D&C. So maternal assessment includes vital signs every 15 minutes. We want to assess for signs of placenta separation and expulsion. While we're waiting, we're going to assist with APGAR scores at 1 and 5 minutes after birth. We're going to observe the mother and family's response to the newborn. Observe the nurse administering the oxytocin medicine as ordered to ensure firm fundus and prevent hemorrhage. We're going to provide pain relief measures, keep the patient informed of placental expulsion and perineum repair if needed, assist the healthcare provider with perineal repair, explain medications if they're given, and facilitate the attachment process by delaying eye prophylaxis so the baby and mom can focus on each other. And we're going to wrap the baby and the mom together for skin-to-skin contact. When possible, we want to provide private time for the parents to bond, and if desired, we want to encourage the breastfeeding. Now, as that placenta starts to separate before its expulsion occurs, I should say, you might see that firmly contracting uterus rise up in the abdomen, like the one picture a few minutes ago. The uterine volume shrinks from the contractions. Now that the baby's out of there, right, the uterine volume isn't as high, so that shrinks, and we see a sudden gush of dark blood from the introitus as the uterus contents are expelled. It looks like an apparent lengthening of the umbilical cord as that starts to break away from the wall of the uterus and enter down, and she feels vaginal fullness as the placenta is delivered. Now this lovely picture is called the Dirty Duncan, and it's the maternal side of the placenta. The healthcare practitioner examines it after delivery to verify that there are no missing lobes. But all those lobes are where it was attached to the wall of the uterus, and that offered the blood supply and the transfer of waste products to the mom. So if a lobe was still attached to the uterus, we would notice that it was missing in the sequence of lobes that are there. And if it's still attached, once the placenta comes out, it can bleed from that site and cause hemorrhage. So they want to get in there and probably do a D&C to try to remove that attached lobe. So our goal is to prevent excessive bleeding. So we want to monitor for a firm fundus post-delivery. If the fundus is boggy, we want to massage it until it's firm. If the uterus is firm and bleeding continues, have the healthcare practitioner examine the patient to rule out vaginal or cervical lacerations that didn't get repaired. And it's becoming more and more common that people are taking their placenta and turning it into powders or capsules so they can consume it. It's been known to give them a lot of energy, so there's all sorts of cultural practices. But we want to respect cultural traditions regarding the caring of placenta and its disposal. So following delivery of the placenta is the fourth stage of labor, and that goes until the vitals return to normal and bleeding stabilizes, averaging 1 to 2 hours. The fundus is firm at the midline, at or 1 centimeter below the umbilicus. We want to massage the fundus, make sure the patient's voiding, make sure the Pitocin in the IV is completing, and if she continues to bleed, we may have to give some IM methogen. Her vaginal discharge is going to be called lochia rubra, and that's that little bit, it's a redder shade. Ensure the fundus is firm because uterine atony is the leading cause of postpartum bleeding or postpartum hemorrhage. That's a test question. Be sure you know that. I'm sure Tony's going to be covering that in her PowerPoints. So another good thing for the fourth stage of labor to help her recover quickly is if she's going to be breastfeeding, get that baby to the breast because that's going to release hormones and cause that uterus to firm up and contract, and it'll speed up her healing and returning its body to a non-pregnant state quicker. So on box 1616, we want to review the assessment in your text during the fourth stage of labor. This will be covered in greater detail in the following chapter. If the patient receives an epidural, spinal, or general anesthesia, after delivery, we need to be sure to assess the patient to make sure the patient's stable. You want to monitor and document vitals and activity, respirations, color, blood pressure, and level of consciousness every 15 minutes for an hour, just like you did in Nursing 121 when you had your surgical experience. Epidural and spinal anesthesia wears off gradually and differs with each patient. So provide for the mother's and newborn safety. The first time she gets up to go to the bathroom, that leg could collapse under her. So make sure when she's standing, she wants to sit at the bedside for a minute, then stand. Make sure she has something to hold on to, and it's not the baby, or it's not the baby's crib, because we wouldn't want her to flip that or something if she falls because the leg gives out. Okay, as we review assessment during the fourth stage of labor, found on box 1616 in your textbook, we want to measure the blood pressure every 15 minutes for the first hour, assess the pulse and regularity, and we want to measure that every 15 minutes for the first hour, determine the temperature at the beginning of the recovery period and after the first hour of recovery. And for the fundus, we want to position the woman with knees flexed and head flat. Just below the umbilicus, cup your hand and press firmly into the abdomen. At the same time, it's vitally important that you stabilize the uterus at the symphysis with the opposite hand. Lay the fingers flat on the abdomen under the umbilicus and measure how many finger breadths or centimeters fit between the umbilicus and the top of the fundus, so between your belly button and the top of the fundus. The fundal height is documented according to the agency guidelines. For example, it's 1 finger above or 1 finger below the umbilicus. If the fundus is not firm, massage it gently to contract and expel any clots before measuring distance from the umbilicus. Place hands appropriately, massage gently, only until firm. Expel clots while keeping hands placed, as in figure 19.1, with the upper hand firmly apply pressure downward toward the vagina. Observe the perineum for amount and size of expelled clots. I find more often it's the resident or the healthcare provider that does that as opposed to the nurse, but some nurses may be doing that. Regarding the bladder, we want to assess for distension by noting location and firmness of the uterine fundus and observing and palpating the bladder. A distended bladder is seen as a suprapubic round bulge that's dull to percuss and fluctuates like a water-filled balloon. When the bladder is distended, the uterus is usually boggy in consistency, well above the umbilicus and to a woman's right side. So as you're doing that fundal check, even postpartum, if you can't find it and it's sometimes way off to the right, it may be because her bladder is filling up, and so we're going to want to assist her to getting up or assist her on a bedpan to void, and then reassessing that to make sure that it's the fundus is becoming more midline. If she can't void or she has too much swelling, we may need to straight cath her. And again, we want to reassess after voiding or catheterization to make sure that the bladder is not palpable and the fundus is firm and at the midline. We want to observe lochia on the perineal pads and linens under the mother's buttocks. Determine the amount and color. Note the size, the number of clots, and note order. Observe the perineum for the source of bleeding. And I don't know if you remember, but I mentioned that if the fundus is firm and she still continues to bleed, we want to have the healthcare practitioner come back in and assess for vaginal or cervical lacerations. Okay, so for the perineum, we're going to ask or help the woman turn to her side and flex her upper leg on her hip, lift the upper buttock, and observe the perineum in good lighting. It's imperative that we do that. It's an uncomfortable procedure sometimes to get so personal, but it's really important to see if there's a hematoma, excessive swelling, and we just want to make sure that everything looks okay. So assess the episiotomy or laceration repair for redness, edema, ecchymosis or bruising, drainage, and approximation. Assess the presence of hemorrhoids. And if your patient received an epidural, spinal, or general anesthesia, assess to make sure the patient's stable. Monitor and document vitals and activity, respirations, color, blood pressure, and the level of consciousness every 15 minutes for an hour, just like you did in Nursing 121 when you were in your OR rotation in the recovery room. The epidural and spinal anesthesia wears off gradually, and it can differ with each patient. So we always want to provide for the mother and newborn safety. So when she gets up to go to the bathroom for the first time or to void for the first time, you want to make sure if she's had an epidural or a spinal, she's going to dangle her legs. When we know she's not dizzy and she feels okay, we're going to have her stand, but we're not going to want her to hold on to the baby crib or make sure that the baby's not in her arms the first time she gets up, because our leg could give out on her, and we don't want that crib or the baby, God forbid, go flying. So we want to make sure that we're assisting her and that she puts her call light on before she attempts to get up for the first couple times after an epidural or spinal when it's worn off. So the nurse would assist the laboring woman into a hands and knees position when the occiput of the fetus is in a posterior position, the fetus is at or above the ischial spines, the fetus is in a vertex presentation, or when the membranes rupture. What do you think is the best answer? I'll give you a minute. The correct answer is A. The hands and knee positions is an effective position to help rotate the fetus from a posterior to an anterior position. Remember how we talked about in simulation where anterior position is going to have the head fit better and it's going to be an easier delivery than sunny side up or a posterior position. All right, well, thanks so much for joining me. Take good care of yourselves. Good luck on your test and the remaining part of your class. Have a good night.